Hi, my name is Sarah Cherny, and I'm a genetic counselor at Lurie Children's Hospital in Chicago, Illinois. Thanks so much for tuning into this talk today. It's a privilege to be able to talk to you about this important topic. So, I'm going to start by talking about the word psychosocial itself, and it simply means that the individual cannot be separated from their environment. And you can see it in kind of three groupings. So, you have your psychological here on the top, you have your biological, and your social. And I've highlighted just kind of a few aspects of each of these areas. And you can see in the psychological component, this is issues that we talk about with our families a lot: quality of life, how well they are doing in coping with a diagnosis or their condition, and then certainly cardiac anxiety, which is a unique feature of our patient population. And then over here on the biological side, we have what is their genetic test result, what is their actual cardiac phenotype. So you can imagine our heart failure patients might have a different experience over their lifespan than perhaps our arrhythmia syndrome patients, what medication and devices are being used to help mitigate their condition, and then are they expected to have any progression over their lifespan. And then the social component of this is certainly very important. This includes family dynamics, what social support, components are there in their daily experience? Do they have the finances and resources to even access care and those support resources? And then what equity and inclusion burdens is this family or this individual carrying due to the society in which they live? Another way to think about this is in the family and social systems theory. And so, as we all know, our individual or our patient is within the context of their family. And this can be just the patient and their parent relationships, but also can be beyond that. And in these relationships, you have important considerations such as their incoming belief systems and perceptions, such as what is the cause of their disease, or how do they perceive themselves in the context of what their ongoing condition might look like through their lifespan. And this may be different for the individual and for their parent or family member. And then how do those individuals within the family system communicate and make decisions together? Certainly for our young patients, the decisions are being made by the parents, but as our patients get into their teenage and young adult years, that decision-making and communication process becomes increasingly complex and important. And then those kind of sets of belief systems and perceptions, the communication styles and decision making all integrate into the relationships, and whether the relationships between the patient and their family are strong or if they are struggling in the context of cardiac disease. And then, of course, just as said before, the society in which this family unit lives has an impact upon them. And this, again, is about community support and access, and also incomes here kind of a fear of discrimination based on their diagnosis or their genetic findings that led to or contributed to their diagnosis or their condition. So when we think about kind of the psychosocial environment of patients and families coming through with the genetic testing process, I've shared a word cloud here, and these are words from my own experience with genetics in families that we care for, but then also from the literature behind the psychosocial impact of genetic testing process. And so what you can see is that there's quite a lot of words here, and they're really diverse, right? So we have some words that are kind of positive, some words that are kind of negative, and then things that are really quite neutral. And so I want to have you keep these words in mind as we go through the next part of this talk, which will be to talk a little bit about the genetic testing process itself and share some family stories from my own clinical practice. So the testing process kind of has four parts. You have the pre-test decision making. Is testing the right choice for this patient and family, whether they do or do not participate in testing, what the results may mean or not mean for them and for their family, and then how they incorporate those results into their sense of self, their diagnosis, and the way they interact with their family after the testing process is complete. So in the pre-test setting, certainly the question is testing right for me? Is testing right for my family? And there's a lot of work out there about the decision-making process. And what I'm going to highlight today is that most families are not thinking about their diagnosis. They're not thinking about genetic testing in the context of care plan. What they're thinking about is themselves in the context of their families. They're thinking about planning the future. They're thinking about seeking an explanation to help them understand how this happened. And importantly, they're thinking about the risk for their children and their family members. There is certainly, as I mentioned before, fear of discrimination. The cost and insurance has become an increasingly difficult component of my care for families over time. Some families will choose not to have genetic testing because there will not be a change to their care based on the test result, and others simply prefer not to know that information either at all or at this time. And there's some great work, again, there's great work out there about this area. And I just wanted to highlight some work from Bourdain and colleagues in 2020. And just simply that even in this adult cohort, so this study was done on adult patients, their primary reason for doing genetic testing was for their children, to understand if their children might be at risk. So let's talk about a couple of families. So I'm going to bring you this family in the context of a positive result. And our proband here for this family is actually the mom. So she had a clinical diagnosis of long QT when she was younger. However, she had a kind of negative experience with her medical care and some of her providers. And that led to incomplete care for her. And she was a little bit lost to follow up. Unfortunately, recently in the past year, she did have a sudden cardiac event, and this was witnessed by her partner and her children. And the CPR in that setting was conducted by her oldest child. And so from that event, from that moment in her life, she is now certainly experiencing PTSD. It did also lead to genetic testing, which did identify a KCNH2 variant, confirming a diagnosis of long QT type 2. So the family came to us in pediatrics here. All 4 kids came to get clinical screening and genetic testing. And clinical screening identified that the twins, the 2 here in the middle, both had phenotypes for long QT, and genetic testing confirmed that the phenotype and the genotype matched up for this family. And what I want to really highlight here is how the PTSD from mom has affected her ability to kind of grapple with this diagnosis for her children and her fear of what they might experience going forward. So she herself had a sudden cardiac arrest. She herself had this traumatic event. And so, of course, she's afraid of that happening for her children. And so the cardiac anxiety in this family is, in fact, the mom's cardiac anxiety about her children's outcomes. And so we work with her to help information help her. So kind of knowing that we have this diagnosis early on, that we are here as a team, that we're here to help her and support her and her children as they move through kind of living with this diagnosis and living with what this means for them going forward. The next family I want to share with you is in the context of a negative result. And so this is a family that actually came to us in the post-mortem setting. So the first person to have a cardiac event in this family was this young woman. She died at the age of 19 suddenly. And we were at that time unable to gather any information about that. She had been, kind of unknown to healthcare prior to that event. And no autopsy was completed and no post-mortem genetic testing was completed. Unfortunately, a second young person in this family died suddenly. There was an autopsy and there was a possible question of ARVC on the autopsy. However, we don't really have a strong confirmation of those findings. And then finally, the third sad story for this family is that a third young person died at the age of 18 suddenly again. What is different in this situation is that we were able to do postmortem genetic testing for this individual, and we did identify an RYR2 pathogenic variant, which does confirm a diagnosis of CPVT for this individual. And then from there, the next step is cascade screening through the family, and the 2 connecting relatives here unfortunately had passed away. And so we were able to get genetic testing on the grandparent here. And just for a moment, I want you to take a second to think about his emotional reaction to this information. He is phenotype negative. He is 61 and doing fine. And so here he has learned that he carries this mutation that led to the deaths of 2 of his children. And so certainly that's going to have a dramatic emotional impact on that individual and this family as a whole. The next step, of course, is additional phenotyping and genotyping in the family if we can. We did do phenotyping for these additional 2 young folks, and they did both have some ECG abnormalities. And we were only able to do gene testing for this one, and she also did test positive, and so we are continuing to follow her. But the person who has cardiac anxiety now is me, because this young person has been lost to follow-up. I'm really concerned. I'm worried that she may also have the same RYR2 mutation. information, but unfortunately, we've not been able to get in contact with her or her parent. Um, so think about your own feelings and how your emotional reactions might actually reflect what your families are going through as well. So I told you that this was a negative result story, and actually the person we're talking about here is this one. So this parent over here tested negative for the familial RYR2 variant. So you can imagine how relieved she is that she doesn't have the same variant that is assumed to be the cause of death for her sisters, but certainly some grief and some loss in that moment there as well. And it does also mean that her children are released from care. They are not at risk to have inherited this variant because she did not. That is kind of the end of the story for this branch of the family, of course, within the context of sudden loss and, kind of a strong emotional weight of this negative test result. So finally, I want to briefly talk about variants of uncertain significance. We talk about these a lot. They come up in a great majority of our test results. As a matter of fact, about 75% of our results do come back with an uncertain variant. And I just want to highlight that the majority of test results that are variants of uncertain significance, they do take a long time to reclassify. You need to be 90% certain that a variant is likely pathogenic before you bump it up into this category. And you need to be 90% certain that it's benign before you bump it down. And so variants that are uncertain can stay uncertain for quite a long time. And families are living with that uncertainty as well. We are uncertain about the variant. They are uncertain about whether it has any impact on their family or their child. And so an example I would like to give you of a result that we got for a young person who had sudden cardiac arrest, and here is their result. So we're trying to figure out, the family would like to know why this young person had a sudden cardiac arrest, and you can see that we do have kind of an interesting result here, but it's in a recessively inherited gene, or so we thought. Call me up and I'll tell you more about this family, but certainly we have all these uncertain variants in the rest of the result. And so when this result pops up, you yourself probably feel an emotional reaction to it, maybe a sense of being overwhelmed or being daunted or frustrated, and certainly the family is going to feel those feelings as well. All right, so the last piece I want to tell you about uncertain variants is that the emotional complexity is really similar in a lot of ways to the other, decision-making process about testing itself. So parents can feel, or families can feel relief both about an upgrade or a downgrade. They are, again, looking towards a certain result. They're trying to get some certainty about understanding their disease or their child's disease. Perception is very important. How they come into the process of genetic testing can be significantly affected by how they're introduced to the idea of genetic testing by their providers, how that conversation is handled, understanding the expectations and limitations, and then the way in from the participants in this study is that these expectations and communications is really important. So kind of even going back to that family systems, how do we as providers integrate into the perceptions, communications, and relationships that the family comes into the clinic with? In the post-test setting, it actually turns out that the results of the test themselves are not as important as how the testing results fits into the existing psychosocial background of the family. So what is the individual and the family's baseline emotional states? Are they having anxiety? Do they have depression? What stressors are happening related to the disease itself? Are they at risk for heart failure? Are they going to have to get a device? And then how are the relationships coming into the room and then going forward as they learn to cope and learn and move as a family into this kind of new state of living with cardiac disease? So to wrap up, I just want to bring us back to that individual within the family, within the society, that social system, and then highlight that we as providers also work as a team. So certainly in the genetic testing process, I have the privilege as a genetic counselor to kind of be the leader for the family and the team as we go through it, but I have the privilege of working with a great team of physicians and APNs. And then one thing that I see in our heart failure colleagues that I would really love to see more in the electrophysiology clinic is the inclusion of psychology and social work. Those individuals materials can really help families navigate and negotiate and understand, how genetic testing and genetic test results can move with them into their diagnosis and their care. And then finally, if we take the time to really educate our families, normalize the experience and contextualize the experience of genetic testing and genetic testing results, we can have a nice, strong, trusting relationship with them, and then they will feel good about their care that they're receiving from us. So thank you so much for tuning in. Please do contact me and follow me on Twitter. I'd be happy to talk to you some more about this topic or any of the families that I have had the privilege of working with. Thank you so much and take care.